Morning everyone. First of all, I welcome you all for this breakfast course on endophthalmitis. Cataract surgery is the most common surgery which is being performed worldwide, and we are used to see a white eye next day with 6/6 and N6 vision. But it is not uncommon that we encounter a certain amount of inflammation on day post-op 1, and the challenge here is to differentiate whether it is a sterile or infected. The inflammation can occur in these 4 scenarios. Now coming to the first scenario, when we know that the patient had a long duration of surgery than the routine time, that is in grade 5 cataracts, or we are needing extra steps like using a CTR ring or iris hooks, in such cases the more than expected inflammation can be expected. Or if you had an atraumatic surgery, but on first day examination on slit lamp, you see a beaked pupil or a minimal subluxation of the lens or PCT. This speaks of that there was a traumatic surgery and minimal inflammation is expected. The second scenario is when the eyes are already predisposed to more than expected inflammation. That occurs in a congenital cataract or a traumatic cataract, or you have operated on an eye with healed uveitis, patient with Fuchs iridocyclitis, or a patient with history of rheumatoid arthritis. Up to 20% of all the cataracts we perform is on diabetic eye, and 10% severe fibrinous reaction is seen in these diabetic eyes. But the challenge is to differentiate it from endophthalmitis, as these eyes are also more prone for endophthalmitis. But the real challenge what we face is if we had a traumatic surgery in a non-predisposed eye, whether this inflammation is sterile, that is TAS, or infective. TAS, as we all know, occurs because of a non-infectious substance which enters into the anterior chamber, causing the toxic damage. To differentiate it from endophthalmitis, it is early in onset. You see a corneal edema which will be from limbus to limbus. You might see some signs of iris damage. But the most important feature to differentiate it from endophthalmitis is the absence of vitritis, which you will see on slit lamp examination. When you do retroillumination, you will see a red glow even if there is a densest of the pupillary exudates. But yes, there occurs some sight-threatening complications of TAS if not treated, that is permanent corneal decompensation, intractable glaucoma, and cystoid macular edema, leading to permanent loss of vision. Now coming to how to evaluate such cases. Let's get back to the history. Patient with history of using topical medications like miotics or prostaglandins bound to have more than expected inflammation on day 1. Arthritis, more chances of endophthalmitis. Dermatitis, infectious in nature. Patients on immunosuppressive, infectious. Nephropathy patients, more chances of infectious in nature. While in diabetic patients, it can be TAS or endophthalmitis. Now coming to our classical teaching, that endophthalmitis presents with 3 cardinal symptoms of blurred vision, pain, and hypopyon. But these 2 studies have clearly shown in the proven cases of endophthalmitis that these 3 cardinal symptoms may be absent in 20 to 25% of the cases. So a thorough clinical examination is must in every case, from visual acuity to the posterior segment evaluation. Visual acuity is must not only because of the medico-legal point of view, but also it helps in guiding us the treatment part. On slit lamp examination, if you see sty or a dry eye, the more chances that the etiology is infective. Wound leak or wound infiltration or the suture abscess on slit lamp examination speaks of endophthalmitis, while if you say vitreous in the wound, that speaks of the traumatic surgery, so more in favor of TAS. In this picture, if you see the first picture, the limbus to limbus corneal edema is in more in favor of TAS, while the other pictures which are Shown here, the ring infiltrates or the complete corneal involvement is seen in endophthalmitis. Anterior chamber grading is to be done according to the sun grading system. Pupillary reaction is to be noted in every case, but usually it is masked because of the exudates or the use of the mydriatics. Decentered IOL or iris fixated or sulcus fixated IOLs speaks of the traumatic surgery. IOP is raised in TAS and it is low in endophthalmitis. Posterior segment evaluation is to be done only by using indirect ophthalmoscope, and this grading is done depending upon the visibility of the retinal details. In case of opacities or the hazy media, B-scan is done to see the involvement of the vitreous and the other structures. In this patient, when the B-scan was done on lower gain, the vitreous was clear, but when the gain was raised, it shows the moderate opacities, and so the importance of doing B-scan only on the higher gains. These three patients were referred to us as a case of endophthalmitis, but B-scan helped us in reaching the diagnosis. The first case was of nucleus drop. The second, in which there was IOL reverbs were seen on the B-scan. In the third case, it was both the nucleus and the IOL drop. The simple vitrectomy with removal of the nucleus and the IOL helps us in attaining the vision of 6/6 in these patients without any use of intravitreals. Choroidal detachment on B scan speaks of bad prognosis. If you see inflammation of ocular coats or the T sign is a sign of panophthalmitis. Now coming to the management part. Even after the detailed history or examination, sometimes we are not sure whether it is TAS or endophthalmitis. If not sure, just increase the frequency of the topical steroids and antibiotics and do a repeat evaluation 4 to 6 hours later. If you are still in doubt or if you see the worsening, then you should treat that case as infective case. Aqueous tap or vitreous tap is to be done in all the cases, in all the suspected cases, and it is to be followed by the injection of intravitreal antibiotics. Whether you do the aqueous tap or a vitreous tap depends upon the ease and the availability of the vitreoretinal surgeon. But yes, the limitation of aqueous tap is that the isolation rate is less than 30%, while with the vitreous tap, the isolation rate is around 60%. But vitreous tap is never to be done by using a syringe and a needle. It is to be always done in the OT by using a vitreous cutter. As a VA surgeon, we always do a complete vitrectomy and send the sample and is used as a diagnostic and a therapeutic procedure. After obtaining the sample, you have to send the sample for microbiological study. PCR has advantage of increased isolation rate, but its limitation is the non-availability in all the centers. The antibiotic sensitivity is not possible and chances of high false positive cases. Negative cultures are seen in fastidious organisms or insufficient sampling, while we need to repeat the culture if we are suspecting fungus or the contaminants, or if there is poor clinical response despite the use of the best antibiotics. If needed, repeat intravitreal injections are to be given only after 48 to 72 hours. This is a chart of various intravitreal drugs which are used with the dosing. To summarize, inflammation is a real-time emergency and thorough clinical and medical history is to be evaluated. B-scan in cases of hazy media should be done. If you are suspecting TAS, increase the frequency of topical steroids and antiglaucomas, and if in doubt, obtain a vitreous sample with intravitreal antibiotics, and if planning a vitrectomy, it should be complete. Thank you.
Thank you, Dr. Shilpi, for your presentation. And I think Dr. Shilpi has covered a lot of theoretical aspects, and now we know how to differentiate endo from sterile inflammation. I will. Wait a second. I will be discussing, we have a slightly overlap of all of our presentations. So I'll just concisely say what Dr. Shilpi has said by the applied, more of the clinical in the applied part, and then we'll decide for the management whether to go for a medical management or a surgical management. So first of all, I thank AIOC for giving me this opportunity, and a very good morning to all of you. So for this breakfast session, ये second presentation, मैं यहीं से चला लूँगा, बंद कर दूँ. Second, yes. So Dr. Shilpi has already stressed on the importance of the early detection, and my presentation is that early diagnosis is the key, because if we miss an endophthalmitis early in its stages and say it's a sterile inflammation, then probably we could lose our eye because of this grave complication. So I don't have any financial disclosures. So this is just to summarize, because this is a repetition. So it is very essential to differentiate these two conditions, because the management is difficult and a delay in diagnosis may result in grave outcomes. So she has mentioned the cases in which we can have an exaggerated reaction. She has already enumerated all the types of patients which can have an exaggerated reaction. But the thing is, suppose if the patient does not have these conditions, there is no complicated surgery, there is no uveitis, then we are in a great doubt that whether this is sterile inflammation or this is endophthalmitis. So this is an important thing to distinguish. So endophthalmitis, by definition, it is an infective process which is predominantly in the vitreous cavity, and it involves the anterior chamber, and it can also spread to the contiguous structures. So we can classify endophthalmitis into severe acute form, mild acute form, or chronic delayed form. The severe acute form is the one which presents usually at day 1 or day 4 as sterile inflammation. The mild acute form is the one which will present about 5 to 7 days or even after 14 days. And the chronic delayed form usually occurs after 4 to 6 weeks, and it is usually due to P. acnes or fungal infection. So how to differentiate? I'll just discuss the clinical. In the onset, the inflammation is usually present on day 1, and endophthalmitis is usually not present on day 1, except in fulminant cases which can present early. Hence, it is more essential to distinguish, because these fulminant cases can lead to loss of vision. So as Dr. Shilpi also said, so pain is not a very important criteria. Only 70% of the patient with endophthalmitis had pain. So absence of pain cannot exclude endophthalmitis. So anterior segment inflammation would be present in both the cases, but if a hypopyon is present, we should always err on the side of endophthalmitis, and we should be more aggressive in our treatment, and we should consider it as not as a sterile endophthalmitis and as an infective case. If on ultrasound we see the presence of vitritis, then it is more likely to be endophthalmitis, which has also been stressed in the previous presentation. So response to steroids. Suppose if I have a patient with a hypopyon, and I think probably this is sterile inflammation, and I start the patient on intense steroids. Sterile inflammation should improve with steroids, whereas endophthalmitis will not have any improvement. So if I've started on steroids and the patient does not improve in about 24 hours, then probably I would like to go for an intravitreal injection or probably even surgery, depending on the vision, which I'll discuss in my next presentation. So if in doubt, always be safe, consider it as endophthalmitis. In the presence of a hypopyon or significant vitritis, we should always err on the side of an infectious endophthalmitis until it is otherwise proven. So as she has said, we have to obtain samples. I personally don't think that aqueous samples are the ideal one which we should take. They do not give us sufficient sample and is diluted. It is always better to obtain a vitreous sample before starting any treatment if you want to isolate an organism. So this is just a grading of the severity of the endophthalmitis. This was based on the EVS time, so the management was different, but now it has changed. A grade 1 is the one which has got a good glow. The vision is less than 6/12. Grade 2, we can visualize second order vessels, but the vision is decreased. It is below 6/12. And in grade 3, some retinal vessels are visible hazily. In grade 4, there is a faint glow, but retinal vessels are not seen. And in grade 5, there is no glow. So this classification was very important in the EVS era, but I also think now it is very important for the management of endophthalmitis, because glow is a very important factor in deciding the treatment. If there is a poor glow, we should not wait much and we should start the treatment. So this is the management which should be done by an anterior segment person. He should try to obtain the vitreous samples with a vitreous cutter. If possible, give intravitreal antibiotics. Systemic antibiotics should be started. The quinolones and the 4th generation quinolones, they have shown good penetration into the eye, and even in cases of sterile endophthalmitis, there is no harm in starting a 4th generation quinolone. Even ciprofloxacin, but moxifloxacin has also shown a good penetration. They should start it. And the role of systemic steroids is controversial, but in cases of post-operative endophthalmitis, steroids should be given to reduce the inflammatory component. So this she has already discussed. So this is the sending the samples, and this is just the showing the frequency and the dose of the various intravitreal antibiotics. The most common ones which we use are the vancomycin and ceftazidime, which are given because the early phases it is usually a bacterial infection, which is usually sensitive to vancomycin and ceftazidime. So these are the drugs which we give, vancomycin and ceftazidime. Dexamethasone may be given or not be given. Some people prefer it. I personally do not like to give dexamethasone. I would like to give topical steroids or oral steroids along with it. So the role of steroids, as I just said, is a bit controversial, but in acute post-operative cases, the inflammation is quite intense. There are a lot of toxins. So steroids should be given to reduce the negative effects which are caused by the infectious course. And they will also help in reducing the steroid inflammation. So sometimes probably it could be a mild endophthalmitis only which improve with steroids and antibiotics. So it's difficult to differentiate, but at the end we want a patient with a good vision. And even if our diagnosis is in slight dilemma, I think it does not matter. So as I just also previously said, sterile inflammation will improve dramatically with steroids. So this is just to summarize the difference between a TAS and an infectious endophthalmitis. The onset usually is early in TAS. Pain can be present in both of them. In endophthalmitis, usually pain is present, but absence cannot exclude it. Intraocular pressure may increase in TAS. It may also increase in infectious endophthalmitis, but usually it is not elevated in endophthalmitis. Anterior chamber inflammation can be present in both the cases, but however, if there is a hypopyon, we should always err on the side of an endophthalmitis. Vitritis is very rare in TAS, but it can be present. In endophthalmitis, it is present because the source of the infection is in the vitreous. And visual acuity is decreased in both the cases. So just to summarize, the management is the best prevention. The proven one is to use 5% povidone iodine, which the eye should be properly cleaned. It should be instilled into the conjunctival cul-de-sac, and it should be left for a minimum 3 minutes. Taping back the lashes in exclusion from the surgical field is also recommended. There is no need of cutting the lashes, and any local or systemic source of infection, if present, should be ruled out and treated before any intervention. And single-use instruments are always preferable, especially the tubings. So thank you very much. So I will just go straight to the next presentation, in which we will discuss the management, whether we should go for an early surgery or we should just continue with intravitreal antibiotics in a case which is a proven case of endophthalmitis. Pen drive se chalana. E. It's an E. End of. So now with the advancement in the vitreous surgery, so now whether we should wait and we should follow the traditional approach of giving intravitreal antibiotics, waiting for 48 hours, doing an ultrasound and then repeating it. Probably these concepts have changed. Even in the ESCRS, they've said that probably early vitrectomy we may have good outcomes. So this is the main thing which we will be discussing in this presentation. So EVS is one of the most multicentric major studies which have been done for endophthalmitis. We can't ignore it. So first I'll just discuss what was EVS about. So EVS recommended a vitreous tap, anterior chamber sampling and intravitreal antibiotics in case the vision is less than hand movements and a vitrectomy plus intravitreal antibiotics in case the vision is less than hand movements. Sorry, in the first case if it was more than hand movements, and a vitrectomy in case the vision is less than hand movements. So by that means if you remember the grading, if the grading is less than 4 or 5, we do a vitrectomy, otherwise we'll go for intravitreal antibiotics. So according to EVS, systemic antibiotics did not appear to have any effect on the course and the outcome of the endophthalmitis. However, this does not hold true again today because the antibiotics which they used were amikacin. But now we have got quinolones which have been shown to have good penetration into the eye, and they can achieve MIC levels and also inhibit the growth of the bacteria. So EVS also used the inclusion criteria was also who those develop endophthalmitis 6 weeks after a primary IOL implantation or a secondary IOL implantation. So also the inclusion criteria was also quite limited. So what were the risks which were considered for early vitrectomy? In a fragile necrotic retina, if you do a vitrectomy, there are chances of breaks, it can lead to retinal detachment. And there is also difficult in the surgery because of this presence of media haze, this presence of corneal edema, this presence loss of inflammation. So we can in the end we can hurt up the retina. So these are the problems which can happen with the early vitrectomy. So these are the conventional guidelines according to EVS. If the vision is less than hand movements, there is associated retinal detachment, there is presence of a foreign body, or if it is not responding to intravitreal antibiotics, if you have given 2 or 3 intravitreal antibiotics after waiting for 24 to 48 hours and there is no improvement or there is worsening, then we go ahead for a vitrectomy. So now why this concept of early vitrectomy? See, simply injecting an intravitreal antibiotic may not control the disease. The cell wall of the organism is toxic, and the bacterium also secretes various oxytoxins. So this volatile mixture will shrink down, will settle at the macula, and it can also damage the eye. So as I just said earlier, there's an evolution in vitreous surgery. We have got improved instrumentation. The traction on the retina has reduced. So probably we can also now perform a vitrectomy without much traction on the retina, with high cutting rates, without causing any complications. So now coming to what are the benefits of early vitrectomy. Early vitrectomy, since it removes most of the vitreous, we just have to do a core vitrectomy in most of the cases. It will decrease the bacterial load. It helps to decrease the inflammatory destructing cells. It reduces the amount of the exotoxins which are harmful to the retina and the other intraocular tissue. It will help to increase the retinal oxygenation, and it also helps to provide a larger specimen. With the help of a cutter, you can have a larger specimen for diagnostic evaluation. In case it does not even respond to vitrectomy, we can probably use the higher level antibiotics like imipenem for intravitreal injections, even piperacillin. So it can also be considered as a prophylactic measures, because as I said that these toxins from the bacteria and the cells can lead to damage to the eye. It can lead to hypotony and phthisis. So it can also help to prevent long-term complications which can happen if left untreated. So I think this is just a repetition, and it also, there's one more point is that it increases the access of the retina to the intravitreal administered pharmacological drugs. So just again, I just want to, because before going into any further discussions, I just want to show this classification once again, because earlier we used to operate when the glow was grade 4 or grade 5, but now I would like to operate even probably in grade 2 if I see, and I'm sure that this is an endophthalmitis. The surgery is much more easier if you operate earlier rather than waiting. In a grade 2 or grade 3, I just have to go inside, do a core vitrectomy, give intravitreal antibiotics. The job is much more easier done. However, in a grade 4 and grade 5, the surgery is much more difficult to be done. These are different cases. These are not post-operative cases. Traumatic and bleb-related endophthalmitis. They are more fulminant, more fulminant strains involve these. They are more severe. The damage is much more. So probably early vitrectomy has a better prognosis in these cases, and vitrectomy should be done. So this is a case in which the patient had traumatic endophthalmitis. She had a honeybee sting, following which she developed a severe endophthalmitis in the eye. So we just explored the injury site. A stinger which was present was just removed, and then we closed the site, and then we went for, this is a slightly old video, we went for a vitrectomy. So this is a case in which there is advanced endophthalmitis. The only treatment is vitrectomy. So I removed the lens, cut some of the uveal tissue, and then after removal of the exudates, we can see that there is a partially healthy retina is visible. Silicone oil was also injected in this eye at the end of the surgery. So these are just the pre-operative and the post-operative pictures, in which in the first case you can see a hypopyon, there is presence of a seclusio pupillae, there is presence of a total cataract, and after doing the surgery we can see a relatively clear anterior chamber and a clear cornea. The best corrected vision in this patient had improved to 20/80. So this is a case in which only vitrectomy is the only solution. We can't go ahead only with intravitreal antibiotics if you want to save the eye. So now I'll be showing two more cases. These two patients, they presented with endophthalmitis where they had been operated on the same day. In one patient, the endophthalmitis was slightly more, so we decided to undergo the surgery only after 2 days after the primary surgery. And in the other, we gave antibiotics, and we decided to probably wait because probably it may improve. So this is the first case. So the media is relatively clear. There is a posterior capsular opacification. I'm just clearing it. The eye does not look very bad. I've already de-epithelialized the epithelium to have a more clear media. So in an endophthalmitis vitrectomy, we have to do a step-by-step approach. We have to first clear the cornea. We have to clear the anterior chamber of all the exudates with the help of whatever instruments you need. That will show in the next video, and then we can go it for a vitrectomy. So in this case, there are presence of exudates, but the retina is visible. So I just did a core vitrectomy. The surgery is straightforward. You can now use a 25 gauge vitrectomy cutter. You don't have to even apply any sutures. So just I did a simple core vitrectomy. We can see the fovea in this case. It looks pretty healthy. The macula looks very healthy. And this patient did pretty fine. The patient gained a final vision of 6/9 of 6/9 after this surgery, and was pretty happy after the endophthalmitis. This is the second patient in which we decided to wait, but however we had to undergo surgery after 1 week because the patient did not show much improvement after 2 injections and probably even showed some deterioration. So I really thought that I should also have operated this patient much earlier. So as I said, we have to do a step-by-step approach. We have to remove all the membranes which are present in the anterior chamber. So this I'm just using a 25 gauge ILM forceps to remove the exudative membrane which is formed in the anterior chamber. So you have to form the anterior chamber with a viscoelastic, remove all the exudates so that we have a relatively clear media. And then I proceeded with the surgery. So you can see the exudates are much more in this case as compared to the first one. And we can see the presence of some retinal necrosis and hemorrhages and exudates which are present on the optic disc and the macula. So although we did a vitrectomy, in this case I did a more complete vitrectomy. I had to induce posterior vitreous detachment also, because in fulminant cases I usually use silicone oil also. And I'll just discuss the roles of silicone oil. So if you're injecting silicone oil, you have to do a more complete vitrectomy. The surgery becomes slightly more challenging. Had I operated this patient earlier, like the first one, probably I would have just done a core vitrectomy. So in this case, I'm doing as complete vitrectomy as possible, but we have to induce a posterior vitreous detachment if we are injecting silicone oil. So we can see more exudates and a more complicated surgery in this. So in this case, I did a more complete vitrectomy. I injected silicone oil. Now the silicone oil I have removed, but the patient has gained a final vision of only 6/36, and we can't do much for it because the endophthalmitis has probably caused damage to the optic disc and the macula. But she's fine. Her best corrected vision is only 6/36. So when to use a silicone oil? The indications of silicone oil: if there is a presence of associated retinal detachment with endophthalmitis, if there is extensive fulminant severe endophthalmitis in which there is retinal necrosis, or if you have created some breaks or a dialysis during vitrectomy, it's always better to put silicone oil because it will help to prevent further complications like a retinal detachment. So it also provides a clear media the next post-operative day, a relatively clear media. We can see the status of the retina. One important thing is it causes compartmentalization. The organism cannot grow inside silicone oil, so it also helps to control the infection, and it helps to restore most of the ocular anatomy and the functions in cases of severe endophthalmitis. So just to summarize my whole of both of my presentations, so this is a treatment algorithm which we usually follow for endophthalmitis. If there is a good reflex of 2 or 1, then probably I will give intravitreal injection. I'll wait for 24 hours. If there is no improvement, I would like to go for a vitrectomy straight ahead and not wait much. But if there is an improvement, then we'll just continue with the medical management. And most of these patients, if they improve, then with intravitreal antibiotics, then they do very good. So the take-home message is that the EVS study deserves a lot of credit because it is one of the best studies which have been done for endophthalmitis, and even after 2 decades, no such large multicentric studies have been done. But however, it is the time to again to re-evaluate the role of vitrectomy with the advancements in vitrectomy, with these newer generations antibiotics. The treatment of acute endophthalmitis have changed a lot. So now we have a better understanding of the pathophysiology. We have got safer vitrectomy machines. We have got better visualization during surgery. And we have got better techniques for retinal reattachment. So the probably early vitrectomy, I think, is now more. We should go inside the eye more frequently than before. And silicone oil should be reserved for the more difficult, worse cases. And I think it is a good option for severe cases because the bacteria also do not multiply in the silicone oil. So thank you very much. And we can also discuss some cases. For the audience, like when do you think that it is a sterile end-off, when we should go ahead, when it is a case of a simple uveitis, and when we should undergo a treatment for endophthalmitis. If anybody from the audience has any questions first, so first we can attend that.
Dr. Bhuvan, see, predominantly the crowd is anti-segment people. So you said about use of steroids whenever in doubt, a trial of steroids. Does it mean oral or it means a topical steroids? Can you highlight it?
In a case of post-operative endophthalmitis, if the patient has got following cataract surgery, I think oral steroids should be given and topical should be given. If the cornea is not involved, then we should also start topical. But if you feel that there is an involvement of the cornea, there is probably a pus point at the cornea or an abscess, then we should not give topical steroids. But oral steroids, I think I would like to give in almost all cases because we usually avoid in fungal cases. But in early cases, the fungal infection is very, very rare.
So the concept is, if in doubt, if on a first post-operative day you see an inflamed eye, you are seeing an inflammation more than anticipated, we should increase the steroids. That means only topical, correct?
Yeah, and probably we can also add 4th generation quinolone along
exactly. With it. So it does not mean, please, in case on a post-operative day 1, if you see an inflammation which is more than anticipated, increase the steroids means only increase the frequency of topical steroids along with some cycloplegic. Never use oral steroids whenever in doubt between a TAS versus an infective. Dr. Bhuvan is talking about use of oral steroids only as an adjunct to a medical or a surgical management of endophthalmitis, not as an independent treatment modality.
Once a diagnosis of endophthalmitis has been confirmed.
Yeah.
I think I'm audible. In the second case that you opted for a delayed vitrectomy. And in a delayed vitrectomy, sir, definitely the posterior detachment, most likely there are chances of inducing breaks. In such case, I think it will be preferable if I go for a core vitrectomy, then debulk all the organisms, wait for the response, and then go for silicone oil in the second go.
See, the concept previously was about doing a core vitrectomy only in cases of endophthalmitis. As Dr. Bhuvan has very clearly said that because of the advancement of instrumentation and our better understanding, and the CV study has very clearly established, you should try to even induce a PVD in most of the cases unless you see a retina which is edematous and necrotic, which might lead to breaks. Or otherwise, it should be a complete vitrectomy including a PVD, posterior vitreous detachment, except in cases of a edematous necrotic retina. Yeah.
And especially if you're deciding to put silicone oil, then you have to do a complete vitrectomy.
Can you go for silicone oil in the second go?
Yeah, see, that depends on, I think that's a surgeon preference. If you feel that you're not comfortable doing a more complete vitrectomy at one go, then probably at 2 sittings. So I think that is a very individual option you, because I felt I could do a vitrectomy without causing much complications, so I did it on the first go. So, but if you think that there are chances of a retinal break or you're not comfortable,
Please, go ahead. Yeah.
Thank you. My question is to either of the presenters. In management of endophthalmitis, to err on the side as assuming, or could it be an infective case, is there a place for non-steroidal anti-inflammatories, either topical or systemic?
in a case which has got a severe inflammation, or you can say even a hyperpion, I don't think NSAIDs have got any role in that. I think probably we should go with increasing the frequency of topical steroids on the first day if we think it is even steroid inflammation, and if it is endophthalmitis, or probably if we've ruled out steroid inflammation, then probably we should be slightly more aggressive. But NSAIDs may have a role in a normal cataract surgery without much inflammation, but controlling such inflammation, I don't think NSAIDs have any role.
Steroids are a step ahead of NSAIDs in management of inflammation. So we are using steroids to curtail down. So you will not need a supplementation along with it. You can consider NSAIDs as an alternative to steroids when the inflammation is under control and is on a weaning course. So steroids would be a primary line, and if you are using it, it does not need a crutches of NSAIDs.
How frequently you should give the steroid drops? Frequency means how about every 1 hour? Frequent means sometimes every hour. Every 2 hours, every 4 hours. So what frequency you want to give?
See, even prednisolone you can give it every 1 hour on the first 1 or 2 days. But now I'd also like to mention, since we are talking about steroids, difluprednate is a very good steroid. I think 4 to 6 times of difluprednate would be probably superior to giving 1 hour prednisolone. There is of course a risk of increase in the intraocular pressure, but it is a very effective steroid, and it will probably show its response if it is a steroid inflammation within 24 hours.
So another query is that if you also use the systemic steroid, then the topical steroid will be so frequent or should be less frequent?
So again, systemic steroids would be given as in case of a proven endophthalmitis, not in a case in which we think that it is just a simple steroid TAS or a steroid inflammation. So probably for the first 1 or 2 days we will not add oral steroids. But if the patient has got endophthalmitis, we can give oral steroids along with 1 hourly topical steroids for the first few days, and then we can gradually probably taper the topical steroids much more earlier because of the risk of secondary glaucoma.
I would
But for the
clarify.
TAS, don't recommend any systemic steroid. For the TAS,
Yeah.
don't you recommend systemic steroid?
For TAS?
Yeah.
No.
No need.
No.
I would like to clarify it.
Yeah.
Basically, there is a clinical setting that on a post-operative day 1, it's an inflamed eye. Now you are not sure whether it is infective or sterile in nature, that is TAS. In such cases, you give a trial of topical steroids. How do you do it? You increase the frequency to say an hourly like this. But most important thing, even in doubt, do repeat an slit lamp examination and an indirect 4 to 6 hours later. It should not be that you give them and ask them to come next day, because that window you might miss if it is an infective in nature. No one can vouch that this is sterile, this is infective, be it the best of the vitreoretinal surgeons or be it the best of the anti-segment surgeon. Now the second role is, in a clinically proven endophthalmitis case, how do we use steroids? Usually we use topical steroids. The second course would be to supplement intravitreal antibiotic along with intravitreal steroids. And the third would be to use oral steroids. Usually topical steroids are sufficient when we are managing endophthalmitis either by medical or surgical management. On the day 1, if we are injecting intravitreal antibiotic, it's a point of debate whether we should inject intravitreal steroids along with it. But usually most of us start injecting after the second dose, from the second dose. Oral steroids is a matter of debate, and we need to be careful about it.
I differ slightly. I do not give intravitreal steroids. I prefer oral, but again, I think, as he rightly said, first of all, we should start with the increasing the frequency of the topical, and it's very important to observe the patient the same day in the evening. We always call the patient in the evening and have a look whether it is deteriorating or improving, because if it is deteriorating, then probably we should think of endophthalmitis only.
Thank you.
And just one more thing to add, oral steroids, if you know the patient is a known case of uveitis before surgery and you're doing a cataract surgery, then probably you can even start oral steroids, and you should start pre-operatively topical steroids and oral steroids to control it. So TAS is one entity, but having an intense inflammation, there are other causes also. So if you know the patient has got a pre-existing uveitis or is prone to the reaction, then probably starting oral steroids 2 days before, or topical steroids only, and probably maybe later oral steroids will not cause any harm.
Dr. Shilpi has already mentioned that in a predisposed eye, a eye with a arthritis, a patient with arthritis, a patient known case of Fuchs, or these cases are more prone. Same scenario again with a diabetic eye. Diabetic iridopathy really leads to sterile inflammation in almost 10% of the diabetic cataracts. But challenge here is to differentiate, because otherwise also endophthalmitis incidence is more in a diabetic eye. So that's the way. I think Shilpi. Yeah.
Thank you very much. Please, I'm sorry to ask another question.
No, it's
What is the alternative to silicone oil replacing the vitreous cavity? If you mentioned silicone oil, if you don't want to use, you said silicone oil is preferable, isn't it? What are the alternatives? Is it gas? Is it saline? If you don't use silicone oil?
No, see, silicone oil we reserve it to the most of the very severe and fulminant cases. But in normal cases, I don't think we have to put silicone oil. You can just do a air fluid exchange and leave air only inside the eye. Probably that would be sufficient, and probably not even air. You can just give intraretinal antibiotics and leave the eye under fluid only. Gas, I would not suggest in a case of endophthalmitis. I think silicone oil is a better, because first of all, we can have a more clear media next day, and it helps to control the infection also. With gas, the problem is the infection will tend to, as the gas level reduces, the exudates or the bacteria will tend to settle down on one part of the retina, and probably could be more harmful. I've not had much experience or done any studies comparing these two. But I think in a case of endophthalmitis, silicone oil would be better. I think Dr. Prashant.
Yeah, for a routine case of endophthalmitis, we do not prefer putting a silicone oil unless we create a break. Breaks can happen because of iatrogenicity, because the tissue is very edematous and necrotic because of the infective nature. Yes, there is a group of people who do put silicone oil whenever they feel that the eye is more prone for such things. We err to put a silicone oil if need be after getting the infective component under control. Yes, again about the gas tamponade, if you have to use a tamponade, it means you have created some iatrogenic break. It is better to use a silicone oil, I think.
Endophthalmitis, I think we should use only silicone oil.
Exactly.
Because we can have a view. With gas, it is always very difficult.
It's not only about the view, it needs a long-term support. Inflammation is going to be there for another few weeks. It does not die down immediately, and so you need a support. Tamponade has to be there for a few weeks.
After discussing how to differentiate between sterile inflammation and infective, let's see few examples of how to differentiate the cases. This is the first case. A non-diabetic male with grade 4 cataract underwent uneventful cataract surgery. On first post-op day, the vision was around 6/18, with mild few SKs and AC cells of 2 and flare of 2+, with 1 millimeter of hypopyon. But on retroillumination, there was a good glow, and fundus examination revealed a hazy view of fundus with disc and second order blood vessels were seen. So we just, as the grade of the cataract was grade 4 and expected long duration of the surgery, so we suspected it to be a TAS and just increased the frequency of the topical steroids and antibiotics. And
the audience can also participate, and
yes,
we can
I
probably
think
ask
this
them that
will
what do
be
they think for the management, and then we can. So if anybody wants to say that, what would they like to do if they see such a patient
In such
which
cases,
has been operated with a grade 4 cataract and
that amount of inflammation which you see, there is a streak of hypopyon, corneal SK is there, grade 4 cataract surgery done. What would be your first line?
line of treatment.
What do you think?
First
Is
day
that
operative.
sterile inflammation or infective? It has to be sterile inflammation, and so naturally
On the subsequent day, the cornea is clear, there is no reaction. So now coming to the second case, a young male.
so just the second day the cornea is clear, so we are relaxed, we should just consider this as TAS. Probably if the cornea was not clear or if there's a hypopyon, then we should start worrying.
So another case, a young male, status post vitrectomy for retinal detachment surgery, underwent uneventful cataract surgery with grade 3 NS. So this was the first post-op day picture. So how will you manage this case? There was 2 millimeter hypopyon.
this patient has
Corneal SK.
undergone a cataract vitreous surgery for say retinal detachment previously, and now he had grade 3 cataract. Having undergone cataract surgery, this is day 1 picture. You can see almost 1 to 2 millimeter hypopyon, corneal SK, and on a B scan you see few opacities. What do you think? Sterile, infective? Pardon?
Why infective and why sterile? Yes, sir, but
Yeah,
it's a
that's the
status-
thing. That's a very right of you. Vitreous opacities means that the inflammation is spilling over into the posterior segment. But if you go back to the history over here, it's a vitrectomized, and in such cases, you are going to have inflammation or a silicone oil residues like this.
So we just close follow up the patient. After 6 hours, there was reduction in the anterior segment inflammation and reaction, and we just started and increased the frequency of the steroids. And on follow-ups, we could see there is a resolution of hypopyon, no cells and flares in the anterior chamber. And on examination, fundus examination, we could see the retina very clearly.
So just
Now,
again,
another case.
if the eye has previously gone a retinal surgery or is undergoing a retinal surgery, so there are chances of having an intense inflammation later. So we should not. I think we should do the same thing. We should just start the topical steroids and keep the patient under observation.
Another case, diabetic patient, status post vitrectomy for PDR. So uneventful surgery, same picture, day 1, hypopyon of 2 millimeter with pupillary exudates, and on B scan you could see the vitreous opacities. So in this case also, that because it was a diabetic patient, status post vitrectomy, so we just increase the frequency and keep the patient on close follow-up, and it improved. Now coming to the fourth case, she was a non-diabetic female with asteroid hyalosis on examination and underwent cataract surgery for grade 3 cataract. She had extended rhexis with posterior capsular tear on table, but there was no vitreous loss. So on first post-operative day, this was the picture.
What do you think?
It's a traumatic surgery, non-diabetic patient, but with asteroid hyalosis.
Move. We are short of time.
Yes, because in this case, if we see the B scan, there are vitreous opacities which you can also see in asteroid hyalosis. But how to differentiate between whether these opacities are because of asteroids or because of vitreous involvement? In asteroids, you will see a clear space between the vitreous opacities and the retina, which is not in this case. So we treated this case as an endophthalmitis case, and while doing the vitrectomy, we could see that there were few cortex chunks also into the vitreous cavity, and this patient improved after vitrectomy. Another patient who underwent cataract surgery elsewhere 2 days ago, complains with sudden DOV and redness, non-diabetic patient. So this was the clinical picture when he presented to us. So what should be done in these cases?
There is a suture, there is a corneal
Corneal infiltration and the sutural infiltration. So
And a
these
hypopia.
cases should never be considered or treated as a TAS case. The first sign of corneal infiltration or sutural infiltration, it is a first sign of endophthalmitis, and these patients should be aggressively treated like an endo case. Another case, uncontrolled diabetic female treated elsewhere, undergone cataract surgery 3 days ago and complains diminution of vision since 2 days. So this was the picture.
So this is a picture in which you should not even think. you
Even
know.
think of, yes.
So you
The
should
last
just
case.
proceed for the treatment straight away.
The last case, non-diabetic male, unevenful cataract surgery and presented with ring infiltration, corneal ring infiltration, 1/3 of the hypopyon. In such cases, like sir said, you should not even wait for a single hour, just do the vitrectomy, inject the intravitreals and start treating it as aggressively as you can.
So corneal infiltration spells a very bad prognosis, and it's a real-time emergency, more emergency than a perforated eye. And in such cases, missing even a single minute is criminal. So even if the vitreous facilities are not there, in such cases, do obtain an aqueous tap and inject an intravitreal antibiotic inside the vitreous cavity. That gives us a window. By the time he reaches to a vitreoretinal surgeon, we get a time we can salvage such eyes. So moral of story is that do inject an intravitreal antibiotic at least whenever that gives us a spare time for us to act on it.
And yeah, I just think once the cornea, because it's very important, because once the cornea is gone, then it's even very difficult for a retinal surgeon to do anything.
Exactly. Thank you.
So thank you very much.
Thank you all.
And thank you Dr. Shilpi and thank you Dr. Prashant for your comments, and thank you for the audience for joining us, and I hope we had a very good session. Thank you very much.
फोटो लेना आप दोनों का?